started your timer and here is your question. Right, so if you have read and understood, considering this surgical pathology station, kindly tell me what are your differential diagnoses for this scenario?
Considering the patient is pregnant and also with the
Yes.
present with difficulty breathing and general swelling, I will consider heart failure, congestive heart failure, secondary to mitral regurgitation, or there can be aortic stenosis also. I will also consider, if it is acute presentation, I will also consider pulmonary embolism.
Right. Okay. Can you, right, okay. What else can you think of? If there is a condition in which there is mitral regurgitation, there is a particular name to it. Can you recall that? It also accompanies, I should have written more description like 28 weeks Asian pregnant youthful girl. Would that?
Yes, there can be.
Yes. Can it ring a bell in your ear for something more familiar condition? In which conditions a patient can present, or a young pregnant female can present with these symptoms, and these symptoms can become very serious. Okay, can you tell me what is rheumatic heart disease?
Rheumatic heart disease is a form of cardiac inflammation and scarring that is triggered by autoimmune reaction to infection by group A streptococcus.
Okay. What type of hypersensitivity reaction would there be?
There's a type 2 hypersensitivity reaction where the antibody that is formed against the M protein of the bacteria cross reacts with that of the myocardial tissues.
All right, good. Can you please help me and walk me through with the pathophysiology of this condition?
The pathophysiology is the type 2 hypersensitivity reaction where there is a cross reaction of the antibody against the myocardial tissues, which incites an inflammatory response. And in case of acute condition, there's pancreatitis. In case of chronic condition, due to the recurrent inflammation, there's a progressive fibrosis, which leads to thickening of the valve, then deposits of calcium leading to calcification, and stenosis, and leading to fish mouth deformity.
Okay. How would you classify this condition? In which circumstances it will be considered acute, and when would you consider it as chronic?
In acute condition, usually there will be it will have little effect on the cardiac function, and also if on gross finding there will be only valvular vegetations. But in case of chronic condition, there will be other findings like commissural fibrosis on the gross findings, valve thickening, calcification, stenosis, and also there will be marked cardiac dysfunction, ma'am.
Okay, can you please tell me a few gross findings that you'll find or you'll see in this condition?
Yes, ma'am. Gross finding is like in the acute and chronic condition.
Yes.
Acute condition, we have the valvular vegetations along the line of closure.
Yes.
In case of chronic, we have the commissural fibrosis, which leads to valve thickening and calcification, and also fusing of the chordae tendineae,
Yes.
then leading to the fish mouth deformity.
Yes. On echo. Okay. Can you please tell me what are the few microscopic findings that you'll find?
In microscopic finding, we usually find the ash of bodies, which is a chronic granulomatous inflammation, which consists of a central zone of degenerating extracellular matrix, which consists of lymph cells like lymphocytes, plasma cells, and NHCO cells, and yes, this is found in all the 3 layers of the heart, ma'am.
Okay. Can you please tell me why patients with rheumatic heart disease are more susceptible to present with infective endocarditis?
Yes, because the deformed valve or pathological valve, they are more prone because the microorganism, they adhere to this these deformed valves, and then they they attaches on this surface and then forms a biofilm, and then leading to chronic inflammation, ma'am.
Okay, can you please tell me what is the criteria that is used to confirm the diagnosis?
The criteria is for rheumatic fever, we have the Jones criteria, where we have major, minor, and the evidence of group A streptococcus infection. For diagnosis, we need 2 major or 1 minor and 1 major and 2 minor with evidence of group A streptococcus infection. For major, we have five criteria: carditis, polyarthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. For minor, we have fever, arthralgia, evidence of previous rheumatic fever, rheumatic heart disease, raised ESR, CRP, leukocytosis, and on ECG prolonged PR interval. And on evidence, we have the evidence with ASO titer, raised ASO titer, or positive throat culture with for group A streptococcus, ma'am.
Good. Can you please tell me can you just name one blood test that can be used to monitor the progression of rheumatic heart disease?
We can do follow-up with ESR, ma'am.
ESR, very good. Okay, can you please tell me what modality can you use to confirm, or what investigation can you use to confirm the vegetation on the valve?
We'll do an 2D echocardiography,
Yes.
preferably an transesophageal echo.
Right. Can you tell me what would you find? What would be the features that you'll be looking for on 2D echo?
On the echocardiography, we see the valve status, then we see the ventricular status, and also the pericardium. In the valvular status, we'll see for valvular vegetations, any
You look for valvular
collapse.
regurgitation and
Yes, ma'am. Valvular regurgitation, degree of regurgitation, and we'll see any leaf collapse.
Yes, leaflets collapse.
The mobility, yes. And then we'll also ventricular dilatation, yes, and dysfunction, yes, and pericardial effusion.
Yes, and ventricular dilatation and dysfunction, and chordal elongation and rupture, increased echogenicity of subvalvular practice. Okay, very good. If if still the condition does not resolve, then how do you think it should be managed?
If this patient has presented 3rd and 4th degree heart failure, then yes, usually with conservative management, it may not resolve. So we, yes, need surgically with valvuloplasty or valve replacement in acute condition.
Yes. What measures would you keep in your mind when you are going for surgical procedure?
I'll involve the multidisciplinary team here.
Yes.
Since the patient is pregnant, I'll involve the obstetrician, neonatologist. I'll also involve the cardiologist, cardiac surgeon, anesthetist, and I'll also explain to the patients the status and also to the attendant and the choices of treatment.
Yes.
And also the risks associated, ma'am, because if there is complications during the surgery, I mean during the surgery for the valve, then we might have to do the termination of pregnancy.
What is the most common anticoagulant that you will consider once you're going for the surgery for this patient?
Commonly,
It is warfarin, but she
during
is...
surgery we'll use heparin, ma'am, and after surgery we'll use warfarin.
Yes, think, because after surgery she is probably nursing. Is warfarin safe to give when a woman is nursing? To the nursing woman? This is
No,
the
ma'am.
actual question. Yes. Then what would be the alternative that you'll consider?
I can use other anticoagulant like dabigatran.
Okay. How would you monitor them?
I'll monitor with the
yes.
I'll monitor with the PTI-INR, ma'am.
INR, you can't. That is for warfarin. Yes, this is a homework question.
I'll monitor with the coagulation profile, ma'am.
Yes, which one?
I'll do
APTT.
the APTT, ma'am.
Yes, you have, but then you have to know the reason.